This is Emily Peters, recording for Care of the Growing Family, Unit 5, the lecture on care of the normal newborn. Just a little disclaimer, when I transfer things from PowerPoint onto the iPad, sometimes spacing is a little bit off, so you may have some words overlapping, and I apologize. All right, so some nursing interventions we do for all babies before they go home, and some of these are pretty soon after birth, is we give the vitamin K administration and the hepatitis B vaccine. When possible, we like to do both the vitamin K and the hepatitis B at the same time, doing 2 shots in opposite legs with 2 nurses, and we'll count to 3. We'll do like 1, 2, 3, stick. So the babies technically sort of only gain a pain response for 1. It's kind of like 1 shot instead of 2. We also do screening for all babies for metabolic disorders. And all babies will get a hearing screen as well before they are born. All right, identification of the newborn. This is really important in the process of when these babies are born. We want to make sure that the babies and the mom and one other significant person, whether it's the dad or the sister, whomever that mom's significant other choice is, they will all have a band that will be matching. This band will be used for identification every time that baby is kind of transferred from the parent's room to another room and things like that, so we get the right baby back to the right parent. Some other things that some facilities do, is you can see it in the picture, is a electronic device that is either put on the baby's wrist, their ankle, or sometimes it's hooked to the umbilical cord clamp. This will cause a alarm to sound if it is removed from the skin for so many seconds or longer, or if that baby is close to an elevator or a door and they try to open them or put the baby on the elevator, an alarm will sound, alerting people that there could be a problem. With our days and age and years, these days and ages, we have a lot of people that attempt abductions, unfortunately, and this is one of those reasons we do this. In our corridor, we have had a few. In fact, one lady went to all of the hospitals from Waterloo all the way down into Iowa City, Cedar Rapids, and was trying to get into the units, and we all worked together and let each other know to look out for this person, and she has never been successful. Another thing that I like to try to throw in with the education on abductors or the possible abductions are these people are sometimes single parents, or they have a mental health issue, or they've had a loss of a child, or not a single parent, but a single person that really wants a child. They have maybe had a loss of a child. Some will even, because of mental health issues, feel like they're pregnant, and then when they realize they're not and they've gone on with the story, then they need a baby. Some other things to kind of keep in mind is when we put those signs up on people's houses saying congratulations on the new baby, things like that. Those are things these people are looking for, and then that allows them to find newborn babies easier. So I say try not to use those at your homes, and if you do, just keep them up for a very short amount of time. Some other things we do for identification and everything with these babies is we do footprints and handprints of the babies. The footprints are what we typically use if this baby were to be abducted or, let's say, switched at birth and we thought there could have been a switch. We will compare the footprints of the two babies to get them to the right parent because genetics can take a while. Alright, so the vitamin K shot. The vitamin K shot is given intramuscularly in the thigh and the vastus lateralis. We use a 25 gauge needle, 5/8 inches in diameter. We will do that hopefully within the first hour or so after birth. One of the reasons for this vitamin K shot is because babies do not produce vitamin K in their systems for almost a week, and therefore we're trying to jumpstart that production to help with clotting because at times these babies could bleed out. This is something we do not need to have a consent to give these babies, but we do sometimes have parents refuse it. Let's see, it's typically like a 1/2 ml of a solution. So this is just a picture to kind of give you an idea about right where we would give the injection for either the vitamin K or the hepatitis B, and that darker spot is right there in that vastus lateralis in the kind of the fattier area of the thigh. We will kind of pinch it up to make sure that we're doing getting a good amount of skin. Eye care. We will do erythromycin for these babies' eyes. We sometimes will delay it we like to do it soon after birth. But we will do it up to an hour later. We sometimes delay it just due to allowing that parent and that child to have some sort of a bonding because it really blurs up the vision of the baby, and the baby has poor vision as it is. We give this to help prevent any kind of infections that could be down in the vaginal canal area. Typically our big things are preventing gonorrhea and chlamydia. However, other infections that are microorganisms that are naturally in our vaginal canal can get to these babies' eyes and cause infections. When we explain it to the parents, we don't mention the STDs pretty much. We just say to help all babies, whether they're C-section or vaginally delivered, get this to help the eyes, protect the eyes from any bacteria it was exposed to, essentially, is the best way to say things. We got to really think about that therapeutic education and therapeutic communication with the parents because we know not all families have gonorrhea and chlamydia, or maybe they don't even know it, but we don't let them just think we are assuming or saying they do. Let's see. Sometimes we'll give tetracyclines if needed. When I'm putting it in the eyes, and you can kind of see them doing it right here, we just put a little bit in the eyes. We go from the inner canthus to the outer canthus. That one vial is for both eyes. We use about half of it on each eye. We let it sit there for a while, and we do not wipe it off. It'll just slowly absorb. Now, if it were to start to drip down into the lower cheeks and things, then you can wipe that off. I just don't remove it from around the eye itself. Here's just another example of us giving the eye ointment. I have found it's easier to give the eye ointment and get that eye open when the baby's either sleeping or quiet, in a quiet state. And when the lights are down, because when the lights are down or off, they're not going to squint or try to close their eyes. All right. So we talked a little bit about some issues with the cardiorespiratory system in other parts of this presentations. Some things that we're definitely looking for are the heart rate and respiratory rate and breath sounds, and observing for any retractions, nasal flaring, fast respiratory rates, things like that. Some other things to keep in mind when we're assessing these babies is the position. They are always supposed to be supine, so back to sleep. When they get put on their side or on their stomach or prone, they tend to breathe shallower and slower, and increases their amount of apnea, and therefore they stop breathing at times. When we suction these babies, whether it's for just cleaning out any secretions or because we think they're struggling and we want to make sure that airway is clear, we always suction from mouth first, then nose. So M to N, mouth to nose. Here's an example of suctioning. If you've never used a bulb syringe, what we typically do is I squeeze it in like you see in that picture, put it in the mouth, kind of back to that buccal area, and then slowly release it, and that will suck the gunk out of the mouth. Same within the nose. And then to get rid of the stuff that's in the bulb, I squeeze it again, squeeze the stuff out. Alright, ongoing assessments and care. Pretty much all babies, when they're healthy, normal newborns, we assess them about every 8 hours, do a full head-to-toe assessment and vitals. When they're first born, of course, we will do some of those things a little bit more frequently. Providing skincare, really babies, all they really need is just to be wiped down with warm water. And sometimes you just need to wash those under the rolls frequently. They don't need a full bath other than maybe a couple times a week. And with that bath, it could just be water. You may only need to use soap once or twice a week. Soap for their hair, you really don't need to wash their hair much either. That might even be once a week type of thing with soap. I believe I have some more slides on bathing, so I'll go into more things there. Same with cord care. We just want to make sure that we have a 3-vessel cord, and we want to make sure that it stays dry and clean. Diapers, changing the diapers frequently. And really wipes are not necessary. You can just make sure with girls front to back with wiping. Honestly, you could just use a warm washcloth instead of buying those fancy wipes. Feedings, every 3 hours or so they should be feeding. Positioning, back to sleep. Car seat safety, they should always be rear facing and make sure their car seat is the appropriate size for them. If it's too big and the baby doesn't quite fit in it, that can lead to increased risk of suffocation and their head drooping down and closing off their airway. Also with car seats, make sure that you don't put anything in it. What came in the car seat in the box when you bought it, that is all you should use with it. They are not car safety crash tested with all those other additives to it, and they cannot guarantee this safety. In fact, some of those things could weaken the straps and cause them to fail and not be as safe. Alright, bathing. Bathing time is fun. Just remember that we don't want to keep those babies in the water very long. We want to make sure that water is warm and slightly cooler than what we typically like it, unless you like it cold. I like really, really steaming hot baths, and that could be too warm for those babies. I want to say like right around 100 degrees. Good places to check the temperature would be on the inside of your wrist, or even with the kind of near your elbow in that fattier part of the arm, if you have gloves on. I always start with the eyes with clean just water, wash from the inner canthus out, do the face, and then I do the head to toe things. Some people say saving the washing their hair for last. I try to wash the hair before I get to the groin area, personally. Umbilical cord care. So, umbilical cord. The umbilical cord can be submerged in the bathtub. There are some books out there that are saying that we shouldn't submerge the babies in a bathtub until the umbilical cord falls off because of infection. Really, as long as that baby's not floating around in that water too long, they can be submerged. You just need to keep it dry unless you're bathing the child. If the baby were to get pee or poop on it, we can clean it with a sterile water and some Q-tips. We don't need to use any drying agents and such to help the umbilical cord fall off. It should fall off in 12 to 14 days. Circumcisions I will get to when we get to those slides. Skincare. You don't really need to put anything on your kid's skin. No oils, no lotions, and things like that. If you do, just make sure that they are very gentle type of things. No, not lots of perfumes and stuff. Like Eucerins are great. Alright, so this is the cord clamp. It stays on for about 1 day or so, and then we just kind of cut in the one area and it pops off, and as you can see, that umbilical cord is kind of a dark dried up substance. It'll continue to get drier and then eventually it'll fall out. It will eventually kind of be like a tooth when it's ready to fall out, and sometimes it's hanging by that last little cord, or like little stringy type of skin. The same thing could happen with the umbilical cord. We want to make sure we don't pull it because we could break it open and cause infections. Circumcision. So this little guy is going on the circumcision board. We want to make sure that we are properly positioning him or her, or him, because little girls don't typically get circumcised. So you can see that he is swaddled. He has a pacifier, and the mom or somebody is giving them some comfort by putting their hand lightly on their head and a hand on their chest. The worst part for this is the fact that the baby is overly exposed, and then its legs, as you can see, are strapped down, and that's very frustrating to them. Why would we do a circumcision? It used to be said that circumcisions are what helps prevent, by getting that foreskin off, it helps prevent STDs and infections. Really, that technically is not true. If we are doing good cleaning and pulling back on the foreskin and cleaning around it, the risk for infections is no different than if you're circumcised or not. Some other reasons for doing it is, well, dad's circumcised, so the child might as well be circumcised. Reasons for rejecting. It's painful. Honestly, the babies don't see a lot of pain. I'd rather them go through it at this stage than as an adult, personally. Other reasons for rejecting are religious preferences to the dad's not circumcised. When we do a circumcision, we want to make sure these children are always given some sort of pain relief. So I make sure the doctor has a Tylenol ordered, and I will give them Tylenol, like a half an hour beforehand. And then I will do like a toot sweet, so a little sugar water on their pacifier, and it's just a drop because that helps with the pain response and the comfort measures that we saw in the last picture. They will also put an injection of lidocaine around the tip of the penis before they go ahead and cut off the foreskin. So that helps with pain relief as well. Some things to think about when taking care of the kid with the circumcision is the comfort, but also we need to check it frequently after the circumcision to see how the bleeding and healing is. So this is an example of the Gomco. So they split the pupus of the foreskin, and they slide a little barrier over the tip of the penis in between the foreskin. And then they clip it all together with this clamp, and then they just kind of cut around with this scalpel and cut the foreskin off, and then everything comes off and it's open. The tip of the penis is then exposed. When we do this kind of a circumcision, we will want to make sure that we're using a Vaseline continuously on that diaper or on the tip of the penis with every diaper change for a few days, so that as the skin is healing, that does not stick to the diaper. This is a Plastabel. So you end up having, and I have another picture of it as well, you end up having this plastic device that has a plastic ring that is fitting between the pubis and the tip of the penis, and they tie a little string there, and then they just cut off the foreskin. And then this part that the hand is holding on to breaks off, and then the little plastic ring is still in there. As the tip of the penis heals, the ring will slowly fall off. And as that ring falls off, we just kind of let it hang there. Once again, it's going to be similar to like that really loose tooth that is just kind of dangling there. Well, the ring will kind of dangle there too, but it is attached by some of that healing skin. We don't want to pull it because we can open up the wound. Here's another example of the Plastabel. So you can see this plastic ring is still kind of tied on there, and it just slowly falls off over the next few days. I want to say it can take up to a week to fall completely off. And then everything should look like what's in picture B. Picture B is also what we end up seeing, other than it's going to be a little red and inflamed when we use like the gum coat to do the circumcision. So you don't have anything protecting that healing incision. Whereas with the Plastabel, you have that ring kind of protecting the incision, so you don't need to use Vaseline gauze or Vaseline with diaper changes with the Plastabel. Here's just another example of the child that is getting his circumcision. They do have his arms pulled down and him fully exposed. I have found by swaddling them, they tend to deal with it a little bit better than having him completely exposed like that. He is mad because of being tied down and not because of pain. All right, hepatitis B vaccine. We give this to those babies within 12 hours of birth, and honestly, sometimes, like I said, we'll do it within that first hour with the vitamin K. It is also then given other times throughout the infancy with other immunizations. It is given in the vastus lateralis as well. It is a vaccine, so we need to get a consent. All right, hearing screens. So all kids are going to get a hearing screen. The sooner we do a hearing screen, the better, because if there are problems with hearing, if we can get things corrected earlier, the better, the less long-term effects they will deal with. So the big picture with all the cords is the old-time, more accurate hearing screen, but it takes a lot longer for it to work. This one, I say you need, I believe it needs to be in the kid's ears and the electrodes running the brain waves for somewhere around a half an hour, and that baby has to be completely still. The smaller picture is just like a little earbud that is put in the baby's ear. It takes a couple minutes to run, and it can sometimes have a little bit more artifact. However, it runs faster, and sometimes it can be pretty accurate. Once again, this is something I coordinate with whoever's doing the hearing screen to coordinate when that baby's kind of sound asleep. It's going to make all of them a lot easier. It is not uncommon for them to have issues with the hearing screen and need to get them done multiple times. Phenylketonuria is a hypothyroidism, galactosemia, hemoglobinopathies such as sickle cell, congenital adrenal hyperplasia, among other things, are all tests we do on all newborns when they're born. We do a little heel stick, and we take little 5 drops of blood, and they test it for these things, because the sooner we know some of them, we can start altering their diet. The big one is that phenylketonuria. This is an inborn error of metabolism. It is a recessive disorder, and it can lead to intellectual impairments if this child is not put on a proper diet. Galactosemia. Once again, we can just alter a few things with their diet. The hemoglobinopathies and hypothyroidism, things like that. It may just be a matter of just giving them some meds and things. It really depends on what's going on. They do sometimes have false positives, so they will run them twice if we get a positive. And then from there we can do more intense screening. So phenylketonuria, like I was saying, is an inborn error of metabolism, and these kids basically can't eat meat, dairy products, dry beans, nuts, eggs. So basically cereal, fruits, and vegetables is all they can eat. So they have to have a very special diet, and it's very expensive. Formula and breastfeeding, the mom may have to alter her diet. There are specialized formulas. If we don't put them on this special diet, they could have seizures, mental retardation, behavioral problems, things like that. It's a lifelong diet. It's super expensive, and it can cause a lot of issues for the family. And there's lots of support groups out there if you find out a kid has this. There is one in the Quad Cities I know of that the parents really struggled and ended up not feeding the child because they couldn't afford its diet, and ended up being a child abuse case. It's sad. But there's many families that are able to work with it and find assistance, and their children are very healthy. So when we're doing all these labs on these kids, we like to do heel sticks when possible. So we'll warm up the foot. That's why there's a diaper wrapped around the foot. They're putting like a warm, one of those warming pads on the foot to get it nice and warm, so we have good perfusion. And right where those little red dots are, those are our puncture sites. So you kind of go right down from the big toe and draw an imaginary line, and that's about where you want to see it in the outer aspect of the heel. And you kind of do the same concept with the pinky toe and the one in from it. The needle shouldn't penetrate more than 2.4 millimeters, and you just get so many drops of blood that way. We sometimes have to milk the foot to get the blood to come out. We can do urinalysis by putting like a urine bag on the babies, things like that. I mean, certain labs we may have to do venipunctures. But if we can do a quick heel stick, it's easier to do a heel stick on these guys versus a finger stick. Stimulation for these kids. Big thing is talk to them all the time, have that face-to-face interaction. They don't need a lot of loud noises, and they just need light, like a dimmed light. They can't see color, so black and white is fine. Holding them and loving them is very important, because they won't thrive if they don't have that interaction with a parent, of somebody holding them and talking to them. Some of this is just kind of looking at those parents and figuring out what they know. Even if they have previous children, things change, so we always readjust and evaluate where they're going. Some of this stuff may seem like common sense, but not everybody knows it. So just kind of making sure we're understanding everything, and recognizing like what the mom is going through, because postpartum depression is huge too, and making sure everybody's getting a lot of support. more in education, figuring out what their best ways of learning is, modeling, including both parents, making sure we're documenting everything, teaching small intervals when possible, things like that. It's important to teach both parents if you can, because what if they're both sleep deprived, which is probably what's going on. Maybe one parent will catch something that the other one didn't. Always model what we want them to do at home. So if we want everybody to be having that baby sleep on its back, we as nurses need to make sure we're modeling that too and keeping the babies on their back. Family-centered care is important, involving the parents and the grandparents, the children, letting them know what community resources are available, and looking at those cultural things. Multiple births, really you guys don't need to know tons of it, but knowing that it's twice the work. Breastfeeding, they can breastfeed both. In fact, we'll eventually teach mom how to tandem breastfeed. Sometimes one of the twins is sick and one isn't, so we try to get the twins together so that it helps with the bonding of those twins as well. Some places will even keep the babies in one crib together because of the bonding. Not all places will do that due to suffocation issues. And that's what I was just showing here, is this place is one that will sometimes allow the two twins to be in a bed together. Some will just do it during periods of time, like when the parents are awake in there, and then when nobody's kind of constantly visualizing them, then we separate them into separate beds. Discharge. Just making sure everybody knows what's going on. Follow up. Checking the car seat to make sure everything's set up correctly and the baby fits in it okay. Making sure that the parents are knowledgeable and has resources. Recognizing when to call the doctor, what is normal and not normal with those stools that we've been talking about, how to tell if the baby's eaten enough. So remember, if the baby's eaten enough, they should go to sleep fairly soon. Afterwards, they shouldn't stay awake for hours between feedings, and typically they should feed about every 3 hours. They shouldn't go longer than 4. And that is just a question for you guys. I am trying to think of what the answer is. It is B. All right.